Welcome to week 10. This week we are going to go through 3 PowerPoints, so we'll just get started right away. So the first is going to be just on some lab tests. We've already been talking a lot about different lab testing in coagulation already, but we're just going to go through some of it again and delve a little deeper into a couple other things. So first of all, we all should know by now that for coag, our tubes are usually the 3.2% sodium citrate, which are considered our light blue top tubes. Very essential to get that 9:1 blood to anticoagulant ratio. In other words, you have to get a full tube. On a lot of the light blue tubes, if you look, there's usually like an etched line toward the top. It's usually the line that you need to get to that line in order to have a nice full tube to work. So if you ever get a short draw where you're not filling it full, then it will prolong our coag results. It kind of like makes, the test will become prolonged and inaccurate as a result. We'll not know if that's truly because of the patient or because of the short draw. So we're centrifuging these light blue tops. In hematology, we were using everything whole blood because, well, we were looking at blood cells, so we wanted it the blood. But in coag, we're actually centrifuging and looking at the plasma for our sample. So order of draw, very essential with light blue, with any tube, but light blue especially because it is the first tube collected. So when you were in phlebotomy, or if you're going to be in phlebotomy soon, you should have learned that the first tube collected was your light blue sodium citrate, or you can collect the light blue after a serum tube. It's a little tricky because years ago, the order draw used to be that serum, the red top, was always first and then your light blue. And so you might see a lot of techs still draw that way. And then they changed it to light blue was first and then the red serum. It gets tricky. In our phlebotomy, we teach light blue and then serum. But if you were to ever see a tech go and do serum and then light blue, it's okay. It's nothing bad because remember, serum doesn't have anything in that tube, so it's not going to contaminate our light blue if it's drawn right before it. So that's totally okay. I know that some people, when they draw with a butterfly, because there's all that extra air in the butterfly tubing, they will put on a serum first because with the light blue needing to be full, they don't want air filling up the vacuum in there, so they want to make sure they can get a full tube, so they'll do a serum and then they'll do a light blue to make sure that it fills full and not full of air out of the tubing. So you might see that commonly. So just kind of an FYI on that. Of course, no hemolyzed samples. We try to have no hemolyzed samples anyway, but with coag tests, hemolyzed samples will actually jumpstart the pathways early, so you get all sorts of weird results. So you can't use hemolyzed, except there are some new analyzers now that we will discuss in a PowerPoint here today that work on a mechanical type detection. So actually hemolysis doesn't affect them as much as it does with like the light reading or, you know, photo optometric reading ones. But again, general practice, not have hemolyzed samples. And then length of time, it goes fast. So for PT tests, we need to test that within 24 hours. For PTT, it has to be within 4 hours. So we can't just let these sit around forever. Long-term storage, there is a way to take the plasma out of the tube and store it and freeze it for about 2 weeks if we really needed to. Aspirin, again, remember anybody that's on aspirin will affect any sort of platelet function assays that you need to do. So that will definitely prolong that bleeding time. So platelet function tests. If we think somebody has a platelet abnormality, which is a common thing, quantitative abnormalities are common, like low platelet counts, but qualitative can happen as well. So if you see those signs of platelet abnormalities, again, it's all that mucocutaneous surface bleeding, such as petechia, purpura, epistaxis, we can do platelet function tests. We've already discussed the bleeding time. This is not really done at most facilities anymore. It's very rarely done. Still need to know what it is because you do have a few places throughout that do like to bring it up and use it. Your boards could still ask questions on it because people are using it still, but majority of the hospitals and clinics out there aren't doing a bleeding time. But again, the purpose to a bleeding time was, of course, to assess the platelet function. So they do this by putting a blood pressure cuff on the arm, set it to 40, just to control that kind of capillary pressure in the forearm. Then they will take a special lancet. It's a bleeding time lancet. It is not the same thing as a capillary lancet. It is different because it is 5 millimeters long and 1 millimeter deep. So it is made differently for the bleeding time. And essentially you're doing this on the underside of the forearm. So kind of, you're always drawing blood out of the antecubital. We're going to go below that in the forearm, and we're going to do it perpendicular across the veins. So you're, so if your veins are running up and down, you're kind of doing it across, horizontally across. So once you make the incision, of course you have cleaned the arm, but once you made the incision, you start your timer. And every 30 seconds, you're blotting that wound with filter paper. And you're not touching the filter paper to the skin. You're only touching it to the droplet of blood. And you're doing that until there's no more blood coming out of the filter paper, until there has been a clot that has been formed by the platelets. And then you stop your timer, and that's your bleeding time. So around 2 to 10 minutes is normal bleeding time. So again, anytime that you have low platelet count or bleeding platelet function being affected, that will cause an increased bleeding time. The other thing would be if they're on aspirin. Aspirin would also cause an increased bleeding time. We have platelet aggregometry tests to help determine what's going on with the platelets. So these are the ones that we've been kind of referencing when we mix different substances like collagen, ADP, epinephrine, ristocetin. Those are all considered platelet aggregometry tests. So normally platelets will adhere to collagen, will aggregate with each other, will secrete their granular content. So that's a normal, typical process for platelets. So when we perform this test, we're assessing that entire process. So what you do is you allow the sample to sit for 30 minutes, just because we want the platelets to kind of come back to themselves and regain what they call their responsiveness, basically kind of get back to their normal state. We have to test though within 3 hours. So after it's sat for 3 minutes, then it's ideal to get it going. So there's different ways to do this. It just depends on how you have it, but the classic method was that you placed the sample into a cuvette with the plastic stir bars. You let it warm up, incubate it for about 10 minutes, and then that stirring device, those plastic stir bars are started, and they basically keep the platelets moving. Otherwise, platelets will settle down, and you want the platelets to keep moving and be suspended. So the stirring will just continue to do that. Now you add your agent, whether it's ADP or epinephrine or something like that. You put that in there, and then you're going to look to see how they perform. Did they aggregate? Did they do the process like they should? So here's some of those different substances, and they can tell you what they're decreased in, what they're in, So by assessing which ones have no reaction, we can kind of get an idea of what maybe is going on with that person. So you do not need to memorize this. This is a lot of information. Just, know for the diseases that we have discussed, like we discussed Bernard-Soulier and Glanzmann and their responses to platelet aggregation. Just know those. You don't need to know each one of these individually. You don't need to remember that ADP will have a decreased response anytime there's aspirin therapy, storage pool disorders, or enzyme deficiency. You don't have to remember that. That's a lot of information. So this is just examples of how this testing works and how they use these results. Again, remember, I cannot talk today. You should remember that anytime ristocetin is abnormal, it has to do with something with the von Willebrand factor, whether it's low decreased von Willebrand factor results as seen in von Willebrand disease, or if that receptor for von Willebrand is missing, which is in Bernard-Soulier. So again, ristocetin is only abnormal anytime it's dealing with von Willebrand factor issues. All right, INR testing goes along with your prothrombin time results. So we've talked a lot about PT, and you've done the PT in class, in which we know that's assessing the extrinsic pathway, but the other thing that happens is when the analyzer gives us a prothrombin time result, it automatically will give us an INR result as well to go with it. So the doctor will get both the PT and INR results automatically on every single patient. And INR is basically a calculation that's done. And it's used for anybody that's on warfarin or Coumadin therapy. It's a marker on if they're getting the right dosage for their therapy. So for people that are not on Coumadin warfarin, we don't really worry about the INR. It's not a big deal. We look at more at the PT results, but it just goes hand in hand. The analyzer calculates the INR automatically, so it's just always given. But the doctor's only worried about that INR for people actually on the oral anticoagulant therapy regimen. So the calculation for INR is the prothrombin time of the patient divided by the mean prothrombin time, which is already put into the analyzer, to the power of ISI. ISI is something that's given to us by the manufacturer for the reagent. So whenever you get reagents in from the manufacturer, they will give you the ISI for their thromboplastin reagent. And so you plug that into your analyzer, and that way it knows how to do the calculation, and it knows which ISI to put it to. So that is kind of the gist of the calculation. And we'll have, in the next PowerPoint, we'll talk about INR again. All right, some review questions. When platelets stick together, it is called, this is tricky because you can either say it's adhesion or aggregation, right? So when they stick together and clump together, it would be aggregation. Adhesion is more like sticking to the surface, if you will. A decreased number of platelets could be recognized by the presence of, and again, all of that is signs of low platelets. The prothrombin time tests which of the following. Again, PT will test the extrinsic pathway. The APTT tests the intrinsic pathway. Coagulation factor associated with hemophilia A, that should be factor 8. Okay, let's go to our next one. The next one is so nice and short. So this is on that INR that we just started talking about. So again, people that are put on warfarin and Coumadin, reminder, it is a vitamin K antagonist, so it affects those vitamin K dependent factors, which are 2, 7, 9, and 10. So basically suppress the vitamin K action, and so those factors are not really functional. And that's what makes it so that it thins out the blood and there's a less chance of clotting. So anybody that's prone to clotting might get put onto this therapy. So there's some examples there. Anybody that has atrial fibrillation, different clotting after traumas or surgeries. If they've had deep vein thrombosis or pulmonary embolisms before, they might get put on this so that it doesn't happen again, that kind of thing. So we use the PT and INR to monitor that therapy. And what the doctor is looking for is an INR between 2 to 3, ideally. So if they're saying between 2 and 3, that's a really good idea that they're on the right amount of medicine and it's working for their condition. Sometimes the range might be 2.5 to 3.5. That's more if they've kind of had like an aortic heart valve put in. Usually it's just the 2 to 3 range. If the INR goes above 4, that is a really bad indicator that they are at risk at hemorrhaging out. Their blood is too thin. They're either taking too much, more than there should be, the dosage is off, you know, something's going on where when their INR gets high like that, it's a critical thing. We have to call it to the nurse or to the doctor right away because that is what we call a critical level. And every lab will have it set. Some labs will say it's an INR greater than 5. Some labs will say anything greater than 4 is critical. So it just depends on what the lab says, but you basically have to call that level because now the patient is at extreme risk for bleeding out because there's nothing stopping them from clot. You know, they won't clot at all because they're too thin. It's too much anticoagulant in their system. So the way that they treat that is the doctor can give them a vitamin K shot because remember, warfarin and Coumadin work on vitamin K antagonism. So give them extra vitamin K and that will hopefully jumpstart those factors to work again so that they can form clots. Another way that they treat it is also giving fresh frozen plasma. So these are a couple ways. I know I actually just I work casually in a lab right now, and we actually just had a patient that had greater than 8 INR, which is so extreme. I think that's the highest I've ever seen it myself. I've never had a greater than 8 before until then, and that was just a couple weeks ago. It was crazy. So that's kind of the gist with INR. We want to see it between 2 to 3. It tells the doctor everything's going well, they're on the right dosage, they're taking their medicine as they should, that kind of deal. Heparin therapy, so again, we use PTT to monitor the heparin therapy. And heparin, the way that it thins blood out is it activates antithrombin. And active antithrombin was one of those regulators that will go and neutralize thrombin and also inactivate factors 9, 10, 11, and 12. And by doing that, it made it so that the pathways wouldn't clot. It stopped the pathways from clotting, which was how it thinned the blood. So PTT, again, monitors that therapy. All right. And going to our last PowerPoint, the last one is on coagulation instruments, so different methodologies on how coag analyzers will work. So there's 5 kind of classic methods on how a coag analyzer might work. It's either mechanical-based, photo-optical, nephelometric, chromogenic, or immunologic. So mechanical is the one I kind of referenced earlier, that actually hemolyzed samples do sometimes work on mechanical, and that's because they're looking at it differently than the other analyzer methods. So this has become big. There is a brand name at the very bottom here called Stago that has really been making its rise up, but it got big for a few years. I don't know if it's still as popular as it used to be or not, but it just depends on the hospital. You might see a Stago instrumentation. But one of the very first ones that started the whole clot detection, and I actually used this back in college, it was the fibrometer, and it was very simple. It basically had one probe that stayed stationary, that stayed still, and then another probe that would move back and forth. And so you'd put your sample in this little container, you'd add your reagent, and then you would start the thing. And then the one probe would keep moving. It sounds like a clicking sound. It was like click, 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 click. And it would keep doing that on a timer, and then the minute it could started feeling the fibrin strands beginning to form, it would stop the timer, and then that was your result. So it's kind of similar to our tilt tubes in that, you know, you're tilting, tilting, tilting after you add your reagent looking for the clot. Well, in this case, it was using a probe to feel for those fibrin strands, and then that would stop the timer. So the magnetic clot detection that Stago was based on was kind of similar, but it used a steel ball instead of probes. And so what it did is it would put the steel ball in there with your sample and your reagent, start the timer, and then the ball would roll. So the ball would be rolling back and forth, back and forth. And the minute that a fibrin clot would start to form, that would slow the ball down. Once the ball slowed down, it would stop the timer, and then that would be your test results. So that's kind of how those would work for testing for PT and PTT. It would just literally look for the slowing down of the ball or the probe, whichever one you want to say, to know that a clot formed. Photo-optical is how it sounds. It's all about light source. So you're having a light source at a specific wavelength passing through the plasma. This is why hemolysis and those other ones cause a lot of problems with these, because they obscure, like if you have any sort of turbidity or icterus or something, it's going to obscure, cause differences in how that light source goes through the sample. So, but anyway, the minute that fibrin strands form, it will cause the light to scatter, and then that will stop your timer, is essentially the deal. So the analyzer will take a little bit of sample, put it into like a cuvette or something, add the reagent, start the timer, and this light will pass through. And again, once those fibrin clots transform, it'll scatter that light, stop your timer. Nephelometric is all about turbidity. It's kind of looking for scattering of light based on turbidity or precipitation. So that's kind of how that works. Similar. Chromogenic is a color producing. Chromo always means color. And then immunology is very similar to nephelometry, using antigen antibody based complexes. So you're not going to have to know a ton of these. This is just more informational at this point. I'm not really going to ask a lot of test questions or anything like that on these. Again, just info. So there's always advantages, disadvantages for all of them. Like I said, the main advantage for the mechanical is you don't have interference from those hemolysis or icterus samples like you do with the rest. But you don't have to know this. This, again, just more info. And then your analyzer might give you some quality flags. So if they think there's lipemia, hemolysis, icterus, it will give you those kind of flags. You should be eyeballing it as the tech anyway. The minute you get a sample and you spin it down and you're going to go put it on the analyzer, you need to always look at that plasma and verify for yourself that it looks like nice, good plasma, that it's not hemolyzed or something. You have to look at it. Your analyzer might also give you flags that are called abnormal clot formation or no endpoint detected. The no endpoint detected means that they were never able to form a clot. There was just no clot ever got formed on this. So those can happen, so you just kind of have to do some troubleshooting. All right, so that last PowerPoint here especially was mostly informational items. And when you guys get into your clinicals and then get into your careers, you will learn what your coag analyzer at that hospital or clinic will do and how it functions and the methodology in it. So you'll get a lot more familiar with it at that point. So that is it for week 10. I hope you guys have a fabulous week. Thanks.